as many questions as I can get to, and I do hope that I leave enough time to be able to get to everybody's questions. We have 40 topics. It's a lot, right? It's a lot of information. And we split them into 4 different sections. So we'll go through the first section, which I think is about maybe 90 minutes, about an hour and a half. And then we'll open up our live chat, in which case you'll be able to type in your questions. Takes like just a minute or so for what you type to get to me. And then I'll read the questions out loud, and I will do my best to answer as many of the questions as I can. So we'll break this up into 4 sessions. It really makes the day go much faster. And just know that I'm here to answer as many questions as I can. So you're going to hear me talk about your partner. And what I mean by your partner is whoever happens to be walking this journey to parenthood with you, right? That can be husband, that can be wife, it could be sister, parent, friend, whoever that happens to be. But I'm going to use the term partner to sort of be inclusive to all. So know that we are going to take breaks, okay? The first one is about 15 minutes. The second one will break for lunch, and that'll be 45 minutes to an hour, depending on how much we get covered. If I'm running short on time, it'll be a 45-minute break. If we're doing fine, we'll take an hour break for lunch. And then in the afternoon, we'll take another 15-minute break. So hopefully it'll go by quickly, right? Because I always feel like a day full of childbirth education is almost like being in labor twice. Once to learn it all, and then once to actually go through it. So hopefully I'll make it interesting and fun for all of us today. So don't close the class out during the breaks. Just simply step away from your laptop or your computer. So a little bit about me and how I plan to support you. Again, my name is Chris. I will be with you all day. I have been a midwife for 30 years, and I actually can't even believe it when I hear the words come out of my mouth that I've been doing this for 30 years. But I have. I've been doing this for quite a long time, and I've delivered babies in several different states throughout the US and a few countries throughout the world. So the thing that I find really fascinating about childbirth and childbirth education is no matter where you are, in what culture, in what context, babies pretty much come out exactly the same way. So women act pretty much the same way in labor, no matter where they are. And to me, it's pretty fascinating. So the other thing that exists, I think, no matter where you are, is there's always this like high level of anxiety about childbirth in and of itself. And my hope is that I can de-escalate some of that anxiety for you today. It's really a very natural process. In the 30 years that I've been doing this, I have never seen one stay in. They all come out, every last one of them. I've delivered thousands of babies. Yours will come out too. So no matter how much anxiety you have surrounding it, the baby is still going to come out, and we're going to make it. I'm not going to say that childbirth is easy, because in no way, shape, or form is it easy, but I guarantee it is the most empowering experience that you will ever have. And I mean that not just for vaginal deliveries, but I mean that for C-sections too. And we'll talk a little bit about that as well. So we're going to open up our live chat. I'd love to know who I'm talking to. So I just kind of like to know who my audience is. So if you don't mind, just to go ahead and type in your name, where y'all are from, maybe when your baby's due. So I know whether you're in, first, second, or third trimester. And if you're having more than one baby, if you wouldn't mind putting that in as well, I would love to know that as well. Okay, so let's see. So welcome to everyone. Tatiana from New York, lovely. Michelle from California. Ryan, hello, Ryan. Britt from LA. So twin boys for Minda and David. So we have a decent sized class today, and lovely. We have people from all over. Ren and Chris from Las Vegas, first baby girl due in May. I think May and June. I have 2 kids that were born in winter months and 2 kids that were born in summer months. And I do kind of think the summer babies are a little bit more fun because you can get outside. Winter babies, as lovely as they are, you're kind of stuck in the house if you live in an area where you feel winter. Right? West Coast may not feel that so much. So lovely. It looks like we have a decent sized class today, and I welcome all of you here. So let's get into our game plan for the day. So we have 4 topics to cover. They're all, I think, equally as important. The first one is labor. The second one is birth and potential complications. The third, which actually, I don't know, you might disagree with me, but I find the most challenging is really your first 100 days as parents. I think we all focus on childbirth, the experience itself and the birth, but really it's once the baby gets here that the work really starts. At least that's how I found it as a parent. I have 4 children, so I've walked this road several times, the one that you're about to walk. So what I will tell you is the first 100 days as parents is really challenging, and part of that is because there's so many, not just physical changes but emotional changes that are going on as well, in addition to the actual act of trying to take care of this newborn that doesn't come with a playbook, right? There's no piece of paper that you can bring home that tells you exactly what to do in every situation. So I do find that to me is the most challenging part. And baby first aid, choking, and CPR. So we don't cover like a CPR certification course, but it is enough information about what to do in the event that you need to call, God forbid, medical services to come help, and you don't know what to do until they get here. We're going to cover all of that for you today. So just know, if you haven't attended one of our baby care workshops, we do have a free online baby care workshop. It's 2 hours. It's like all things baby care. And you're definitely going to get a sign up link in the email that you're going to get after this class. I think the email comes during the earlier part of the week. So before we get started, I do want to make mention of the fact that I know some of these babies that are coming from our couples that are here today are going to be arriving, by C-section. So you're not going to have labor. You're not going to have the same exact fears, but your fears are different, right? So, for some of us, there's things that we need to know, like prior to your scheduled C-section. And, the information around labor will help you, because some of us go into labor before our scheduled C-section happens. So we're going to cover all that. I don't want you to miss that stuff. I want you to be present for that so that we can prepare you in the event. And this just happened to me last night, somebody who was scheduled for a C-section and actually went into labor before her scheduled C-section date. So, we had talked about all that. She knew all about what to expect, and she really wasn't panicked, even though she was having a scheduled C-section. She knew exactly what she needed to do, who she needed to call, when she needed to come to the hospital. So we're going to tackle all of that for you today as well. So, obviously, if you're scheduled for a flat out routine C-section, we would urge you to contact your healthcare provider for any advice regarding next steps should you go into labor and you actually are scheduled for a cesarean. So the nature of labor, right, is such that everyone needs to have a pretty good understanding of the physiology and what happens. And typically, it's going to take a little bit longer to explain that piece of it than it is what to do for your scheduled C-section. But either way, we're going to go over all of that so that you feel comfortable in any event. Because listen, some of us who have every anticipation of having our babies vaginally end up with a C-section as well. So both topics, I think, are pertinent. So let's get into our first topic, which is labor. So how does your body prepare for labor? Like physiologically, what happens? So at the end of your pregnancy, the last several weeks, usually by about 34 weeks of pregnancy, most women are kind of sick and tired of being pregnant, like they've had it. They can't believe there's another 6 weeks left of pregnancy. And why is that happening? Because up until about 32, 34 weeks, your uterus is growing up. And about 32, 34 weeks, it hits the rib cage. So when your uterus hits the rib cage, it's really, really uncomfortable in this area. You actually might touch certain areas of your belly and start to feel like it's almost bruised, or almost like you want to push your uterus away from your rib cage. Totally normal. And then what happens? The only other way to grow is sort of out, right? And as you get closer to your due date, the baby's head starts to become engaged in the pelvis. So it starts to drop. And all that means is that the baby's head has moved down deeper into the pelvis, and now it's in the correct position for birth, right? Think about what happens when that happens. So your uterus is nothing more than a giant muscle. That's all it is. And it will, from time to time, contract. They're painless. They don't really hurt you when you're not in labor. Those painless contractions, right, are called Braxton Hicks contractions. You may have read about them, you may have heard about them. They're harmless. They're your body's way of sort of practicing for labor. They don't last very long. They can last anywhere from 20 to maybe 40 seconds. And you might be going about your day and all of a sudden your brain just kind of focuses on what's happening here. Not painful. You kind of know it's happening. It's not enough to make you stop and have to breathe through it. You might think it's the baby's position, right? You might think the baby is just kind of pushing against your uterus and making it a little bit hard. You may have felt those already. Completely normal. Braxton Hicks contractions are just a normal part of the body getting ready for labor. But no, at 32 to 34 weeks, it's very common for women to just be like, I'm done with this. Like, I am sick and tired of this pregnancy. Almost everybody says it to me at some point once they hit that range. So it's very normal if that happens to you. Okay, a mucus plug. What is that? And what do you do if you see it? So a mucus plug is nothing more than exactly what it states. It's a plug, a sort of glob of mucus that sits within the cervical canal for the duration of your pregnancy, the entire part of your pregnancy. And the whole purpose of the mucus plug is simply to protect the baby, from what's happening outside of your uterus in the vagina, right? While you're expecting. So the mucus plug is something that everybody has. Not everybody sees it when it comes out, right? So it can come out in a glob, like a big form of, people will say to me, they'll call me and they'll say, I think I just lost my mucus plug. And I'll say, what does it look like? They'll say, it looks like snot. Like, I hear people say that. Other people will say, I don't know, it's just this big glob of like brownish. Some people say pinkish, but it's this big glob of mucus. It just fell out while I was in the shower. And then other people will say, I never saw that. All I have is like stringy mucus that continues to come out of the vagina every time I go to the bathroom. A mucus plug can take on that form as well. So it's usually very kind of like jelly-like. That's how I describe it. So I think the slide says it too. Yeah, a brownish or pinkish jelly-like substance. And it can vary in size. I mean, believe it or not, sometimes I have patients that like bring it into the office, and I'm going to tell you, you do not need to bring your mucus plug to the office. Your healthcare provider is going to go, thank you very much, and they're going to throw it in the trash. So what exactly happens with a mucus plug? It's one of the subjective signs that your body's getting ready for labor. I have gotten phone calls where people will say, I just lost my mucus plug. What do I do? And I usually answer, do whatever you were doing before you lost your mucus plug, because it doesn't mean you're having a baby, right? It means you're having a baby sometime. So it could mean that a baby's coming, I don't know, in the next 24 hours. It could be the next 2 weeks. Right? So if you lose a mucus plug, and that usually happens anywhere from 36, 37 weeks on, but if you lose your mucus plug, there's no need to call your provider specifically for that, solely, only for the mucus plug, because we're just going to say, are you contracting? Has your water broken? Are you feeling the baby move? And if all of those things are no, I'm not really contracting all that much. Yes, my baby's moving. No, I'm not in any pain. We're going to say to you, okay, totally normal, nothing to worry about. So specifically a mucus plug, no need to call your healthcare provider. Now, if you have bright red vaginal bleeding that's coming with that mucus plug, yes, we would want you to call your healthcare provider for that. Bright red vaginal bleeding, like a period, is not normal at any time throughout your pregnancy. So if you have bright red vaginal bleeding, you are on the phone. You're not necessarily rushing to the hospital, but you're on the phone, with your healthcare provider to let them know what you're seeing. But a mucus plug is just a sign that your baby's coming, not quite that you're having a baby just yet. Okay, your water breaking. What happens? Water breaking can happen at any time. With one of my children, I think at like 18 weeks, I felt this big gush. And I thought, it can't be, right? I'm only 18 weeks pregnant, but it had to be my first, because I had been a midwife for a while. And I called and I said, I know it can't be my water breaking. And I remember the midwife saying, well, it can be, it would be rare, but it can be. So water breaking can happen at any time. So if you feel a big gush of fluid that comes from the vagina at any time in pregnancy, you definitely want to make that phone call. The much more common case scenario is it happens after 37 weeks. Really, truthfully, it usually happens when you're in labor. So people get really nervous, like, what do I do if my water bag breaks? But I would tell you from personal experience, 30 years of doing this, I think water breaking before labor actually only happens about, I don't know, 7 to 10% of the time. More often than not, it's going to happen while you're in labor, or it might even be that your healthcare provider needs to break your water because it doesn't break. It just doesn't break on its own, even when you're in labor. So just know water breaking can happen at any time. It's more likely to happen again while you're in labor. That's what we expect. The color of the fluid is important to note. So if you have a big gush, water is coming out, coming out, coming out. You want to note the color, right? What does it look like? Usually it's clear. It can be pinkish tinged. It can be a little bit cloudy and white. All of that is normal. If you have greenish fluid, something that looks, almost like a pea soup in consistency, very dark green, or even a faint tinge of green, that can be a sign of meconium, which is when baby actually has a bowel movement inside the amniotic sac. That is something that you're going to want to report to your healthcare provider, that, your fluid actually looks a little greenish, right? We want to know that, because that's somebody I'm going to want to come to the hospital sooner rather than later. So you want to make sure that you note the color. Does it come out as a gush? Usually. Does it come out like a little trickle? Sometimes. So how do you know the difference, right? Like, what happens? This is what I tell my patients, and it's different from what I hear other providers tell their patients. Usually I'll hear oftentimes physicians, if they're on the phone, they'll say, just put a pad on. And if it's wet in an hour, call me back, which isn't bad advice. It's not bad advice, but my advice is usually a little bit different, because at the end of pregnancy, there's so much vaginal discharge that if you put a pad on, almost any woman is going to have a wet pad, just because there's increased vaginal discharge as you get closer to having a baby. Okay, but let's say you just take your underwear off, put on a big shirt, right? And you get up and you walk around for a little while. That's what I tell my patients. I say, don't put a pad on, take everything off, dry the vagina off as much as possible from the initial, whatever it was, gush or trickle that you felt. And then just put on a big shirt, get up, walk around 10, 15 minutes or so. If you feel any wetness now starting to come or trickle down your leg, that is usually your water bag breaking. So it is uncontrollable. It's not like urinating, where you can urinate and stop the flow of urine sort of on your own will, right? When your water bag, it's just water that keeps on coming. In a lot of cases, it literally is enough water to like run down your legs and fill your shoes. So we're talking a lot of water. So a trickle can certainly happen, and that's why I say it's important to call. But more often than not, it's not something that you can miss. I mean, most of the times it's just water that's going to keep on coming, even if you're tightening up those pelvic floor muscles to try to hold it in. You're not going to be able to hold it in. So trickles are definitely important to report. But it more oftentimes feels like a gush. And some women will even say, I just felt like something popped inside my vagina. Now, nothing pops, right? But sometimes it really is a little bit of a release of that mucus plug, and boom, the fluid just comes. So it can come in either one of those forms. If you think your water has broken, it doesn't matter what time, day, night, whatever it is, call your healthcare provider. That's what we want to know. And I need to know for a couple of reasons, things that you're not thinking of. It's not so much if your water bag breaks, because a lot of times you can still be home when your water bag is broken, depending on your pregnancy circumstances and if your fluid is clear. If you want to labor at home, that's oftentimes possible. But I want to know, because I have to coordinate what's going on, either at the hospital or the birth center. So I know if I have somebody whose water bag is broken, that patient's going to need a bed. Right? They're going to need a bed at the hospital within the next, 12 to 24 hours. So that's where your healthcare provider needs to know, not that you have to come in immediately, but that there's some coordination that needs to happen. So take a look at this slide. I do love this slide. Let me pull up a pointer for you so that you can see. If you look, right, at this slide on the right-hand side. So here is all of that amniotic fluid, and it's starting to come right through the cervix, right? And you might feel like a little trickle right there. Look at this slide on the left, right? When we're looking at all of this slide, the placenta at the top, right? The baby's umbilical cord right here. all of this bluish, just it's not, your water's never blue, but on the slide it's blue. This is all amniotic fluid. That's your bag of water, right? So generally when the cervix is closed, you may not feel a whole lot, but it certainly can trickle right through, which is what we're seeing on the right-hand side. And then it would come down into the vagina. And that's when you're going to feel it. So we have lots of acronyms that we're going to go over today, right? And when we talk about your water bag breaking, you want to remember the word coat. What does that mean? So the C represents the color of the water. The O is the odor of the water. Is there any foul or any foul odor? Amniotic fluid should be odorless, shouldn't smell like anything. So if it smells like urine, that you feel something in your underwear, you go to smell, it smells like urine, it's probably urine, because amniotic fluid doesn't have an odor. And if it does, that can be an early warning sign of infection. So that's another thing your provider is going to want to know about. So the color of the water, O is the odor of the water, A is the activity of the baby. We're going to ask you those questions. Is your baby moving? Is your baby not moving? What's been happening? And the time is the T. So what time did your water bag break? The clock kind of starts ticking once your water bag breaks, so 85% of all people will deliver within 24 hours of their water bag breaking, but not everybody has contractions immediately after their water breaks. So for us on our end, as a midwife, I want to know, what time did your water bag break, right? So because prolonged rupture of membranes or prolonged water break, being broken, can sometimes increase a mom's risk for infection. So those are all the things that your healthcare provider is thinking about that you actually might not be thinking about. So as a caregiver, we're going to ask all of those questions. So you're going to want to know the answers to those. So earlier we talked just a little bit about meconium. Meconium is a little bit of a warning sign that the baby could have a little bit of stress inside the uterus. They will go ahead and have a stool inside the uterus, and then that sort of gets mixed in with the amniotic fluid and will give a little bit of a greenish tinge to the fluid, okay? So you definitely want to report that. If you are before 37 weeks of pregnancy and your water bag breaks, that's called preterm rupture of the membranes. Your care provider is likely going to talk to you about starting some antibiotics because your water bag is broken on the earlier side. You may or may not have contractions. If your water bag breaks and there's no contractions whatsoever, then you're, depending on the gestational age, your care provider might say, we're going to admit you to the hospital and we're not going to induce labor. We're going to see how long we can keep you pregnant without increasing your risk for infection. So I had somebody a couple weeks ago whose water broke at 32 weeks. So we really didn't want to deliver a baby at 32 weeks if we didn't have to. So we did admit her. The first 24 to 48 hours is the most crucial time period if somebody's water breaks preterm. And if they don't go into labor, no signs of infection, it's a pretty good chance that you'll stay pregnant for a little bit of time. And then there's some monitoring that goes on, some ultrasounds that go on while you're admitted to the hospital over the course of the next couple weeks. And then most people will induce labor at 35 to 36 weeks if your water bag has broken prematurely, because at that point, there's really no benefit to keeping you pregnant. The risk is actually greater. So if your water bag breaks preterm, your healthcare provider will likely talk to you about giving the baby or giving you some steroids in order to help mature the baby's lungs a little bit faster than they otherwise would have matured. And that is a helpful thing for babies, right? We don't want babies to be born with immature lungs. They have a little bit more trouble breathing if that happens. So should your water bag break prematurely, that is likely a conversation that your healthcare provider is going to have with you. And I actually had that happen with my first pregnancy. Not that my water bag broke. I went into preterm labor. We did talk about steroids, and I did take them. And it does help babies' lungs mature a little bit faster. Let's talk about Group B strep. So Group B strep, or GBS, is something that is, I would say, not wildly common, but common enough that we should discuss it. It's similar to like a strep infection that you would get, strep throat, but it's a different version of the strep bacteria. So that is strep that grows in the vagina. I usually tell my own patients that if you have a vagina, you probably have group B strep in it. And it's a question more of whether it will overgrow at the end of your pregnancy. It's usually tested for between 36 and 38 weeks of pregnancy. And if it is positive, it's a little Q-tip swab, goes in the vagina. If it's positive, we need to treat you for that strep infection, not immediately, but when you come in labor. Why don't we do it immediately? Because the baby is protected earlier. Remember, we said the baby's protected by that mucus plug, and they're living in that amniotic sac, that big, huge sac of water. So they're protected from anything that's in the vagina or anything that's in the outside world when they're in the uterus, safest place for them to be. So if you have group B strep, we usually give antibiotics when you come in labor. The antibiotics that we usually use are penicillin. If you're allergic to penicillin, there are alternatives that we can use. So that's important to know. The alternatives that we can use, clindamycin, vancomycin, those are all antibiotics that we definitely use for group B strep. So no need to worry. Your care provider knows what to use. But that is something that you'll be tested for. And if your group B strep is positive and your water bag breaks, that's an indication that you're going to need to come to the hospital sooner rather than later. Same thing with prematurity. If your water bag breaks and you are before 37 weeks, you're going to be coming to the hospital for evaluation immediately as opposed to staying home. So those are just important things that you need to know in terms of what happens if your water bag breaks at a time frame when it's not really supposed to, right? Or if you have a group B strep infection. Okay. Let's talk about stages of labor, moving right ahead. So now we've hit term, we've been having some contractions, and where are we in our labor? Are we even in labor? Do we know? Do we not? So the first stage of labor is when you're definitely starting to have contractions. Your cervix is actually now starting to dilate and it's starting to thin out. A cervix that is nowhere near labor is very long, like the length of my finger. It can be 3, 4, 5 centimeters. And as you get closer and closer to having your baby and closer to being in labor, the cervix actually starts to shorten. We measure it in terms of percentage. So we might say you are 50% effaced or 50% thinned out. What does that mean? That means, as opposed to having a very long cervix, it has thinned out halfway. 80% effaced, 90% effaced, right? Let me do it here. If this is the length of your cervix, right? 50% effaced might look like that. 80% effaced might look like that. 100% effaced means it's paper thin. So when I put my fingers in, I can't feel any cervix at all. I just feel the baby's head. All right. So that is the very first stages of labor, which first stage of labor is generally, the entire first stage is 0 to 10 centimeters, but it's broken up into phases, right? Early phase, active phase. So just know that first stage of labor is when your cervix is dilating and thinning out. The second stage of labor is when your uterine contractions now sort of increase. You are fully dilated. You are getting ready to push, right? So we know that the baby is going to be delivered in that second stage of labor. How long does that take? We're going to get into it, but generally people push for about 2 to 2.5 hours on average. Now, if you're not average, if you're faster than average, you might push for half an hour, 45 minutes, an hour. If you are a little slower than average, you could very well push for 3 to 3.5 hours. Like this is all normal, all within the confines of, normal. So that's your second stage. Now, your third stage of labor is actually after the baby is out and we need to deliver the placenta. So when the placenta comes out, right? And some people will say there's a fourth stage, like the period of time after the placenta comes out, but labor is generally broken down into 3 stages. First, contractions is 0 to 10 centimeters. Second stage, you are pushing, delivering that baby, right? So the delivery of the baby completes the second stage of labor. Third stage is from the time the baby is born until the placenta is actually expelled from the body. So early labor, let's break down that first stage. Early labor is generally considered 0 to 6 centimeters. If you're looking at some old information on the internet, you might see 0 to 4 centimeters. But the newest guidelines tell us that early labor is anywhere from 0 to 6 centimeters. So those contractions can be very irregular. They can be anywhere from 15 minutes apart to 8 minutes apart to 5 minutes apart, and can be anywhere in between. So you can have a contraction. 3 minutes later, you can have another contraction. You might not have another one until 8 minutes later, right? Very irregular type of a pattern, right? The beginning stages of labor, not so bad, right? You're thinking, I got this, totally got this. This labor thing is not as bad as I heard it was. Okay, so they get increasingly stronger as your cervix dilates a little bit further. So, as a general rule, 1 centimeter, 2 centimeter, 3 centimeters, you're aware you're having contractions. You're not really huffing and puffing to get through those. In my experience, when you start getting to 4, 5, 6 centimeters, it starts to get much more uncomfortable. Now, how long a process is that? It really does vary from person to person. So I've had people come into the office, tell me they've been contracting for 12 hours, and I check them. And disappointingly, I have to tell them, you're not even dilated yet. And they look at me like, are you kidding me? Like, are you joking? How long is this going to take? So you can have contractions for days that are not very painful, but enough to kind of keep you up at night, right? Enough to kind of be an annoyance or a nuisance. All of that can happen. Once your cervix actually starts making change, you're not going to be doing that for days on end. So that 0, 1, 2 centimeters, that can go on for a while. The other thing that can happen is you can contract and actually contract for a couple of days, and you're thinking, oh, I'm having this baby. And then literally, like, it stops, goes away. Fake news, right? And then you sit there and you think, oh my God, I was so close. I was so close. And it just didn't happen. So that happens quite commonly. The other thing that happens that I find is the uterus is actually very active in the evening and at nighttime. So you could have several hours of contractions that you're timing. Honey, could you time that? How far apart are those contractions? And then all of a sudden they stop. You think, if I have one more of those contractions, I'm going to call, and then you fall asleep. You wake up the next morning, still pregnant, right? So it is common to have contractions for hours at a time, not so painful, and then it just stops out of nowhere. So just know labor can be anywhere from, the beginning stages, a few hours, to actually a very long period of time, which is what we call prodromal labor. It's just you're having contractions, your cervix is making absolutely no change. That is the most frustrating part of labor if that happens to you. And oftentimes, your care provider might offer what's called therapeutic rest. They may say, why don't you come into the hospital, we'll give you something to help you sleep. If that's offered to you, I would tell you, take it, because one of two things happens when we offer therapeutic rest. It's usually an IV medication that we give, a narcotic type of a medication, things like morphine. And I know what you're thinking, oh my God, morphine, very early stage of labor. If you're not progressing, morphine can be very helpful. Some people use Demerol. Some people use a medication called Nubain, Stadol. All of those narcotic medications can be given if somebody's in what we call a prodromal labor pattern. And that may help to either kick you into labor or stop your contractions. So if you're contracting for night after night after night and nothing's happening, and someone says, why don't we bring you into the hospital and we'll rest you overnight? I would tell you, as somebody who's been doing this a long time, I think it's extraordinarily helpful for women to just do it, because oftentimes it'll knock those contractions right out if it's not real labor. You don't want to go into labor exhausted, right? Because we need you to be able to push. So that's really important. So just know, if you're in one of those sort of prodromal long labor patterns and your provider says, why don't we bring you in and give you a little bit of rest? I think it's a great idea. Okay. So when we're in the early phases of labor, sometimes we can do things to make the contractions better. Walking around sometimes helps, right? Drinking some, I usually say, like, I don't know, those 20-ounce bottles of water, the sport cap bottles of water, you drink 2 or 3 of those. That may space those contractions out a little bit so that you can get some rest if that's happening at night. Doing some massage, getting in the shower, getting in a bathtub. Sometimes those things will help to kind of relieve the early stage of labor. When your contractions are inconsistent, right? You want to try to do something to make them go away. I know your thought pattern, right? I've been doing this for a long time. I've heard women say, I don't want to make them go away because I want to have the baby. Doing things to try to make your contractions go away is just a way to help you get through the early stages. If you don't do the suggestions that we give you, it's not that you're going to have your baby any faster. You're just going to be uncomfortable for a longer period of time. The body's going to do what the body's going to do. So when your healthcare provider or your labor and delivery nurse makes suggestions to try to help you through those sort of very irregular period in the beginning of your labor, listen to them, take their suggestions, because what you want is to be comfortable. It's what's going to happen to your body is going to happen anyway. So just know, right? If somebody says, why don't you try this, or why don't you try getting in the shower for a little bit, or why don't you try, taking something to help you rest tonight, maybe a little Benadryl. That's what I use for my patients, and seeing if that will help. If it's real labor, you're not going to sleep through a Benadryl. It's not going to happen, right? You're going to kick right into labor, and it's not going to make you so drowsy that you forget what's going on or how to cope with labor. It's your labor is what it is, and there's no medication alive. It's going to make it stop if it's time. So just know that. Okay. Let's talk about cervical effacement and dilatation. Remember, we talked about effacement is the thinning of your cervix. If your cervix is the length of my pen, as labor progresses, it thins out, thins out, thins out, thins out. Normally, with the first baby, your cervix will thin out first, and then it will dilate. If it's a second or third baby, your cervix actually might stay quite thick for quite a length of time. All right. So looking at this slide, this is what we're measuring. When we put our fingers in the vagina and we're feeling your cervix, we're feeling how long the cervix actually feels to us. This is a cervix that's actually not effaced or dilated in any way, shape, or form. Now take a look at this next slide. See how this has now thinned out? This cervix is completely effaced. If you look at the difference between this right here and this over here on the left, this cervix is very long and thick. This cervix is completely effaced. It's thinned out, and it's starting to dilate a little bit, right? So that's about 1 centimeter. And then if you look at this next slide, do you see how the cervix is now starting to open to allow the baby's head to pass through into the birth canal? This is about 5 centimeters dilated. And our last slide is actually fully dilated, which is 10 centimeters. You cannot push a baby out at any other time other than being 10 centimeters, right? So if you're 6 centimeters, you might feel like you have to push, but your care provider is going to say, no, we got to breathe through these contractions. You're not fully dilated yet. Fully dilated is 10 centimeters. In every state, in every country, in every labor, fully dilated is 10 centimeters. You are not pushing before 10 centimeters. So the early parts of labor, physically, your cervix is beginning to thin out, which is efface, right? Effacement. Your contractions can be quite irregular. We're talking about hormones that you may or may not have heard of: oxytocin, adrenaline, endorphins, right? All of those, prostaglandins, those are all hormones that are involved in the very early stages of labor. You might be feeling at that point like your back hurts. You might not be comfortable. You might be feeling like, is there a mucus plug there? You might see it, you might not. Your water bag could break anytime during that period. Remember, we talked about your water bag could break at any time, might not break at all, might need to be broken. Early phases of labor, you're kind of still more excited, talking to your partner, like, I can't believe we're having a baby. Can't believe I'm actually in labor. You're fine, right? Still a little, you still have a kind of a smile on your face. I know when my patients are in early labor, when I show up at the hospital and they're like, hey, Chris, how you doing? And I'm like, put your clothes on and get out of here. You are not in active labor at this point. When you can sort of talk and laugh and smile and watch TV or do whatever you're doing at the hospital or birth center, that's early labor, right? So that is not the real deal just yet. So what do? I tell my patients to stay at home. don't come to the hospital when you're in the very early stages of labor because you're going to be there for a really long time. Have you ever heard somebody say, my labor was 4 days long? And I say, no, no, no. Labor is usually the actual like active labor is generally not 4 days long. Now, you may have been having contractions on and off for 4 days, but it didn't take 4 days for your cervix to actually dilate once you hit, that point where your contractions are uncomfortable. They're not mild anymore when you're in active labor. So, you can stay home. You're still able to eat and drink at that point because you still have a little bit of an appetite. Active labor, no appetite anymore. It goes away. You want to distract yourself. Labor is all about kind of, taking your mind off what's actually going on. You can breathe through those contractions very easily. You might want to take a warm bath. That can be helpful. More importantly, if it's at nighttime, you want to try to rest as best you can. Even though you're super excited, you want to do your best to lay down and rest. So, when we talk about monitoring, if you come to the hospital in early labor, your nurse may just do what's called intermittent monitoring. And that is, something where you're not connected to a machine continuously. So in the early phases of labor, you may not even be at the hospital yet. Your midwife or doctor might say, just be aware. Be aware of what's happening. Is the baby's pattern of movements any different? Are your contractions somewhat regular? Are your contractions lasting 45 seconds to a minute? If you're having 20-second contractions, you're not having a baby. It's not happening, right? So regular normal labor contractions, 45 seconds to a minute in length, each one, right? And generally they're happening about anywhere between 3 and 5 minutes apart when you start hitting the active phase of labor. So early, very irregular. Active phase of labor, much more regular. So early phase of labor, you might want to stay home. If you think that your baby is not moving in the same way that it normally moves, and sometimes that happens in the early phases of labor, baby starts to conserve its energy, doesn't move a whole lot, you want to make sure that you call your provider. I always say, do something to make the baby move. Eat or drink something cold and sweet if you're not diabetic, right? Cold water will work. If you have diabetes in pregnancy, you cannot throw down a bottle of apple juice. It's not possible. If you're not diabetic, you can use something like juice. That's helpful. But even cold ice water will usually wake a baby up and get them moving. So if you've done something to make your baby move, take your belly, move it around, see if you can get the baby to move. And if you're not getting a response, you want to check in with your healthcare provider and just let them know what's happening. So again, in labor, what are we using to kind of distract ourselves? We can use heat therapy. A bath or shower is extraordinarily helpful to relieve pain in labor. And if you're contracting somewhat irregularly, sometimes it is enough to just relax you enough to make those sort of irregular contractions go away so you can get some rest. Once you're relaxed, that actually helps increase oxytocin. Oxytocin is what your body makes when your body's in labor. So oxytocin is a powerful hormone that actually helps to, bring your contractions on in a much more regular pattern. So what I was saying before about, not doing the things that the suggestions that we give you because you think I want to have my baby, sometimes that actually backfires on us. So you want to do everything you can to try to help yourself relax so that your body releases that oxytocin so that increases your levels of contractions. You want to use water that is close to your body temperature, right? And that doesn't have to be like you stick a thermometer in the shower and test the water. You want it to be something that's actually comfortable against your skin. So not scalding hot, not on the cool side, just comfortable. So try not to use anything in your bath water if you're going to actually get in the bath. So don't put any bubbles in there because if your water bag breaks, we don't want any issues with chemicals, being introduced into the vagina. Okay, let's talk about active labor. What's happening in active labor? You are now 6 centimeters to 10 centimeters, and you're not so happy anymore. This is what women look like, right, when they're in active labor. Early labor, hey, Chris, how you doing? Oh my gosh, I want to be checked. I want to know how far apart my contractions are. Here's what active labor looks like. I don't think I can freaking do this anymore. I don't know, Chris. I don't know if I can do it. Okay, there's a big difference. So early labor, comfortable. Active labor, not at all comfortable. All right. Those contractions are not going away despite what you're doing to try, right? You're taking a shower, you're taking a bath, and darn it, those darn things keep on coming, right? So, regardless of how much water you drink, how much activity you're moving around, how much you're trying to relax, those contractions, they just keep on coming. They have a very predictable pattern. So, the pattern of contractions that I look for when I'm looking to bring somebody into the hospital is generally about 4 to 5 minutes apart, each contraction lasting about a minute in length from the start of the contraction to the end of the contraction, 60 seconds. And that's going on for at least an hour. And I actually stretch it out a little bit, like an hour to 2 hours. So look at that example there 5-1-1, 5 minutes apart, each contraction lasting a minute, 60 seconds. And that's going on for 1 hour. That's a phone call to your healthcare provider if you're still at home. Some of you may be at the hospital at that point. Here's what I tell all my patients because this is important to know after all the years that I've practiced. As a general rule, when you are contracting and you get to about 3 to 4 minutes apart, and then that's going on for about 3 to 4 hours, you're somewhere around 2 to 3 centimeters dilated. And most of my patients look at me like, what? Like, what did she just say? But that's the truth. Laboring with a first baby takes a very long time. Now, if it's your second baby, they come zip, zam, zoom, super fast. But most of us that are here today are here because we're having our first baby, right? So that's what happens. It takes a long, long time, sometimes 18 to 24 hours, 12 hours if you're lucky. So if you're at the point where you're getting those contractions 5 minutes apart, each one's lasting 60 seconds, 60 seconds, beginning of contraction to the end of the contraction, and that's going on for an hour, you want to link in with your healthcare provider and let them know what's happening. Those contractions will become increasingly stronger together or increasingly closer together as your labor progresses. That is 100% to be expected. They will last longer than those early labor contractions, which might only be 20, 30, 35, 45 seconds. Labor contractions in the active phase of labor are generally a full minute. Here's what I want you to know. They are very painful. The first 20 seconds, it's like you're just gearing up, right? And this is what you have to think about in your head. You're just gearing up. The middle 20 seconds, really bad. Like they hurt a lot. You're thinking, I can't do it. Like I'm going to die here and everybody's telling me to just breathe. That's honestly what it feels like. And then the last 20 seconds, the contraction's going away. So when you think about those middle 20 seconds, that is really like 4 or 5 slow, deep breaths. I am willing to bet that you can do anything, right? As much as it hurts for 4 or 5 slow, deep breaths. So if you keep that your mantra, keep it. All I have to do is get through the middle 20 seconds. Yes, you're going to be nervous because you know what a contraction feels like, but it's the middle 20 seconds that are really, really hard. And then the last 20 seconds is just going away. You don't have to feel that one ever again. That one's gone. We'll wait for the next one. All right. So, yes, we know that in active labor, your contractions will definitely be stronger. So they will be somewhat wave-like. This is what, you'll always see OB practitioners say, this is what your contraction looks like. So they start out relatively easy. They very quickly become very strong and they peak. That's that middle 20 seconds that we talked about. And then they will just reduce. So it's the peak of the contraction that is going to be the hardest for you, right? When you are at that point, you can't walk or talk through what you're feeling. It is time to go to the hospital. That's what your care provider is going to say. All right, you've been contracting 3, 4, 5 minutes apart. They're lasting a minute in length and it's been going on for an hour to 2 hours. Why don't you come on in and we'll see what's happening, right? And do you have to like drop everything and sprint to the hospital like this slide? No, right? Just get yourself together and get to the hospital. Sometimes it is a bumpy ride to the hospital. Just know that. I want to show you this because this is a really good sort of visual for what happens when you're in labor. Then we'll talk about admission procedure. So if this is your uterus, right, there's nothing more than a balloon, and this is your baby's head. Now, this is simply a ping pong ball, but if this is your uterus, what happens in early labor? Your uterus kind of contracts and releases, right? Contracts and releases. You're fine. Oh my God, honey, maybe we're having a baby. Call your parents, tell them, right? Labor starts to get stronger. Watch what's happening here, the lower third of the uterus. Now you're having longer, stronger contractions. Do you see that? Right? Do you see how this starts to elongate? What's happening up here is starting to push that head right here, which is really just a ping pong ball, but it's starting to very slowly, right, push it out of the uterus, right? So that's what happens. Long, strong contractions. You're breathing, 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 right? And then the contraction simply goes away. So early labor, not a whole lot's happening, right? See that? Lower third, nothing's really going on. You're having short contractions, but those really strong ones, look how that changes, right? So that has the impact that we need in order for that baby to sort of come out. So it's a great visual. I love using that. Okay, let's talk about when you come to the hospital. What happens? You will likely be told how to enter, like how to get into the hospital, whether it's going to be directly through the main entrance to come up to labor and delivery. Sometimes it is through the emergency room, depending on the facility. So you're going to want to ask your care provider, when we come to the hospital, where are we coming? Do we come in the main entrance of the hospital? Do I have to come in through the emergency room? So you'll check in. They will be expecting you because we call ahead of time and let labor and delivery know that you're coming. You're going to want to bring with you your driver's license if you have one, and you're going to want to bring with you your insurance card. Many times you'll have to pre-register at the hospital or the facility where you're delivering, but it is always a good idea to have those two documents with you. Driver's license if you have one, and your insurance card. Just so that if it's not in their system, there's no issues after the fact where you're fighting with an insurance company or fighting with a billing department at the hospital. So bring those two documents with you, really important. So depending on where you're delivering, hospital, birth center, doesn't really matter. Some of us deliver at home. But if you're going to a facility to deliver, some hospitals have what's called an OB triage area. It's not a single bedded room where you'll be the entire length of your labor. It might be a 2 or 3 bedded room that's separated by like a curtain. That may be the initial place where you go just to be evaluated to see if you're in labor. Some labor and delivery units have just what's called a labor and delivery triage area. Same idea. And then in some hospitals, you are more rarely evaluated in the emergency room, right? And then sent up to labor and delivery if you're in labor. But in most facilities, you are going to be evaluated in labor and delivery. Okay, so that's pretty normal. Now, remember I gave you that example earlier, like if I walk in the room and my patients are like, "Hey, Chris, oh my gosh, am I having a baby?" I'm like, "Get out of here. You are not having a baby if you are smiling like that." So if you're not in active labor, oftentimes you will simply be sent home, right? They'll say, "Nope, not in labor. It's not time to go home." And that's frustrating to have to be sent home, but it's really common and it happens a lot. And it's certainly nothing at all to worry about if that's what happens. Next time you will be in labor, right? Some patients come back 2 or 3 times and get sent home 2 or 3 times before they actually are in active labor. If you're in active labor, you're going to be admitted. And that is either going to be to, a single bedded room. I don't know too many hospitals that have double bedded rooms for labor. Most hospitals have converted to a single room type of a model. So you'll only be laboring in a room by yourself. And it's usually called a birthing suite. So we talked about active labor earlier, early labor, 0 to 6 centimeters, and active labor is defined 6 to 10 centimeters. So what is happening to you at that point? You are no longer happy, right? Your cervix is now very likely to be fully effaced. Every once in a while, you could be 80 to 90% effaced in the active phase of labor. And your cervix is between 6 and 10 centimeters dilated. Remember, we said 10 centimeters is the beginning of the second stage of labor, right? Your contractions are now like 3 to 5 minutes apart. They're lasting about a minute in length. And it's those contractions where they're, really, really painful. You're having a hard time breathing through those because what's happening, right? It's starting to push that baby's head down into the vaginal canal. So it's time, to push. Okay. So what are you feeling? You're feeling scared oftentimes. Very common to feel like I can't do this. Like, I can't do this. I need something for the pain, right? You can be very preoccupied with what you're feeling. Your partner may try to talk to you, and you might be like, stop talking. I've had patients tell me, don't talk, right? Stop talking. And I know they're probably at that point, even without checking their cervix, they're likely to be in active labor. You could feel very hot all of a sudden. Just be like, my God, it's so hot in here. That is as a result of our maternal hormones, very common in active labor. And you might never, ever, ever want to be alone. So, you're not going to want your partner to leave the room oftentimes. So it's a scary time. It feels unnatural. It feels frightening. It feels like, I don't think I can do this, right? I feel like more often than not, with all of my kids, when I delivered, even after I had had babies, when I hit that active phase of labor, that self-doubt kicked into high gear. Like, I can't do it. I don't think I'm going to be able to do this. Even after I had done it successfully, you still feel like, I just can't do it. And your labor nurse is going to say to you, you got this. Like, you can totally do this. Just stay with me. It's when you're going to need a tremendous amount of support. You're not so talkative anymore. You're much more serious, right? You're much more focused on what you're feeling and how you're going to get through that contraction. So, what can you do? This is when, if you have the option for hydrotherapy, to get in a tub or to get in the shower, it can be tremendously relaxing, can be really helpful. Your breathing may become now slower and deeper, just to try to be able to get through, especially the peak of that contraction. So earlier I said, if you just focus on doing one contraction at a time, that's it. Don't worry about how many more you have to do. In the hospital that I deliver at, oftentimes I try to take the clock off the wall. I don't even want women looking at how long they've been in labor. I wish every labor and delivery unit did not have a clock, right? Where a patient could look and say, how much longer do I have to do this, right? It's really, it like kind of screws with your mind a little bit. So just know that once that contraction ends, it's gone. You're never going to see that contraction again. It's over. You're one step closer then to seeing your baby. Remember that you still want to be able to drink often and keep yourself well hydrated. This is when you're not feeling like you want to eat anymore. And oftentimes, if you ate in the earlier part of labor, this is when whatever you ate might come back up. Lots of women vomit when they're in active labor. It's quite common. You're likely gonna feel that. Know that, in the active phase of labor, this is when sometimes you start thinking about pain relief as well. And we're going to talk a little bit more about pain relief, but you might start saying, I thought I wanted to do this naturally, but I don't really know if I can do it. I can't. This is not where this, I don't care that we had like a safe word. I'm thinking, forget the safe word. I got to get something for pain. So I always tell people, have some kind of a word, a safe word that you and your partner discuss, that basically indicates to your partner, this is when you need something for pain, because everybody's going to tell you you're doing great, you can do it, you can manage, but you in your head might then all of a sudden say, I can't do it. I can't do it. And that's going to be your word to your partner, where your partner can actually speak for you at that point and say, hey, I think she needs something for pain, right? Most of the time, you yourself are going to say, I need something for the pain, right? But sometimes between the two of you, you might say, I don't care how badly I say I want that epidural. Don't let me get it. I never think that that should be a conversation between you and your partner, right? Because none of us know what our pain tolerance is until we actually get into labor, right? I thought I was great with pain. I was an athlete in high school and college. I had sprained ankles, whatever. That was a joke, right? When I had my babies, I was like, dear God, this is pain I've never felt before, right? So it's a totally different experience having a baby. So just kind of be flexible with what your plan is, and what I'm trying to say. So we do have a video for you about breathing in labor, and we will put that in our link to you on our resource page. So we'll talk about, breathing in the first stage, breathing in the second stage. Okay, monitoring in labor. What does it look like? So, in active labor, if you're low risk, you don't have any high risk conditions, high blood pressure, preeclampsia, diabetes, you may have intermittent fetal heart rate checks, which means that your labor nurse may put either a Doppler, which is a machine that just goes right on your belly, tiny little handheld machine to listen to baby's heartbeat for a short period of time. And she may do that every, 5 to 15 minutes to see how baby's tolerating labor. There is also what's called electronic fetal monitoring, which is continuous. And sometimes that's used even if you're low risk. But in a higher risk situation, somebody who might be over age 35 or have any type of complications within their pregnancy, then you may end up with a fetal monitor, which has two parts, two round parts that are attached to wires that attach to a machine. And one of them goes at the top of your belly that measures contractions, and the other one, which looks round as well, goes on the lower part of your belly, and that's what measures baby's heartbeat. And it prints out on a piece of paper, and it allows your healthcare provider to kind of see what the pattern of contractions and the pattern of the baby's heartbeat is over time. All right. So think about higher risk situations might be preterm, could be if you have meconium stained fluid, maybe if you're being induced and you're using Pitocin, or if you have an epidural, or if the baby shows any signs of fetal distress on intermittent monitoring, if you're trying a vaginal birth after cesarean section. Those are all common conditions where you will have continuous fetal monitoring. You're going to have your blood pressure and your temperature taken on a regular basis in labor. Usually it's hourly. If there's any signs of infection, it may be more frequently. And then you're going to have vaginal exams to kind of see, what's going on with your cervical dilatation. So it really does kind of depend on, what the clinical picture is in terms of how often you're going to be examined. Start thinking of your questions because I'm going to open up that live chat in a minute. But here's what I want to say about vaginal exams. A vaginal exam is necessary oftentimes if you're going to be induced. All right. So if you're going to have an induction, your healthcare provider needs to know where you're starting from in order to I don't know, to know like what they're going to use because there's different things that we use to induce labor. You may have heard of Pitocin. That is a synthetic form of your own oxytocin that you make. It's a man-made form of oxytocin. We use that for induction of labor. There is something called Cervidil, which is a little suppository that's put in the vagina to generally ripen the cervix, make it a little bit more receptive to using Pitocin if you're being induced. There's also a pill that's called Cytotec, which is also a cervical ripening agent. All of those things are things that we use to help get somebody into labor if perhaps there may be post dates past your due date. So we need to know what your cervix is doing to kind of know which direction we're gonna go in terms of helping you to get to a point where you can start contracting. There's also a Foley balloon, a catheter that gets inserted if your cervix is open even a centimeter. Oftentimes we can insert a catheter into the cervix and then inject some saline, some fluid in it so that your cervix starts to open with almost like what looks like a balloon, right? This is obviously large. I'm using this as the, example for uterus, but we might put something in that looks like this, the bottom part, inject some saline into what looks like a balloon. And that constant pressure on the cervix helps the cervix to actually dilate. So there's lots of different ways to help women get to that point where we start labor. But we need to know, that's why vaginal exams are important. Do you need to have an exam every hour while you're in labor? Oh God, no, you do not. Right? Especially if your water bag is broken. Once your water bag is broken, you should try to minimize the amount of vaginal exams that you have simply because we don't want to introduce anything into the vagina that can increase your risk for infection. So just know, right? Vaginal exams are necessary in certain circumstances, but if your provider comes in and wants to check you every single hour, you absolutely have the right to say, can we hold off a little bit, especially if you're not feeling anything. If you don't feel rectal pressure like you have to push, if you don't feel like I don't know, like you feel totally fine. There's no reason for somebody to be checking you. So it's something that you kind of need to speak up for yourself about if you want to hold off on a vaginal exam. So just know, yes, they're important. Sometimes your provider should be able to say to you, I want to do an exam because, and they should have a valid reason why they want to do an exam. So it's not a good idea to constantly say, no, 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 I want no exams. But your provider should be able to say, I'd like to check your cervix because it's been 6 hours, or because I don't like the way the baby's heart rate looks on the monitor, and I need to, start thinking about how this baby's going to come out. Is it going to come out from down below, or is this going to be a cesarean section? So those are things you just kind of want to think about with regards to vaginal exams. Okay, so we're going to open up that live chat. It's going to take a minute or two for your questions to come over to me. But I would love to see the questions that you have, and I will answer them for you. So any questions on labor? Okay. What I'm going to do is I'm going to read the questions, and then I'm going to go ahead and answer for you. All right. So great question from Lindsay and Merritt. If you choose not to have an epidural, are there IV pain medications that can be administered at any time instead? So yes, we are going to talk about this a little bit later, but let's touch on it. So the IV pain medications that are used in labor are narcotic medications. They come in the form of Demerol, Stadol, Nubain. Those are the top three. And we're going to talk about this a little bit more as we get into our next section. But the IV pain medications generally work for about an hour to 2 hours. They're usually given in the very earlier stages of labor when you're not having a baby in the next couple hours, because they can, just like they make mommy feel a little bit sleepy, they can make baby feel a little bit sleepy. So narcotics are a great way to relieve pain, but not a great way to relieve pain if it looks like delivery is imminent. All right. So that's the short answer, but we'll definitely get into that because we're going to talk about all the pain relief options as well. Okay. So a very good question here. Can you get an epidural when you are 2 to 3 centimeters dilated? So let me tell you about some of the studies that have been done on this because they're pretty interesting. We used to think that if you got an epidural too early in your labor, and this is a very, very common thought process. If you get an epidural too early in your labor, that it will stop your labor completely. And I would tell you that that is true in a lot of cases. There was a study, an Israeli study that was done many years ago that looked at epidural placement right at this point, 2 to 3 centimeters dilated, and with very regular contractions, and patients that were self-reporting a pain scale of 7 to 10, right? Those patients were in a lot of pain, but their cervix was only 2 to 3 centimeters dilated. And what they found was those patients that were given an epidural with a self-reporting pain 7 to 10, 10 being the worst pain you've ever felt, even if their cervix was 2 to 3 centimeters dilated, when the epidural was given, those patients actually had shorter labors than women who were holding out a little bit longer. So here's what I'm going to tell you. What's happening up here, 100% in my opinion, affects what's going on down here when you're in labor. So if you come into labor really frightened, very anxious, not coping well with pain, you're likely to not dilate very rapidly. So it is really important when we talk about relaxation and meditation and being able to relax in the early phases of labor. It's really important because you really can feel a tremendous amount of pain at 2 to 3 centimeters dilated simply because we can't let go enough up here to let what needs to happen down here. So the short answer is yes, you can get an epidural at 2 to 3 centimeters. However, there is a chance that if that pain is being precipitated by anxiety and being afraid of what's happening, that if you get that epidural, that you absolutely might stop those contractions. And so for me, my patients, which I train them very early on about what labor feels like and the process and how long it could take. My patients know I prefer somebody get an epidural when they're 4, 5, 6 centimeters. So the short answer is yes, you can at 2 to 3 centimeters. And sometimes it's helpful if you're truly in a tremendous amount of pain. But again, if that pain is coming from fear, a place of fear, as opposed to a place of, physiologically what's happening to your body, there's a chance that when you get that epidural, your labor just stops, your contractions just stop. And then we have to start adding medication to try to bring your labor back. And that starts to increase your risk for cesarean. So just something to think about. But it's an excellent question. And we're definitely going to talk a little bit more about that. Okay, another great questions. Let me see. Hold on. A couple just came in while I was talking. Okay. Okay, when you do get an epidural, this is Debbie asking, when you do get an epidural, is there a point when it's too late to get one? Also, what's the difference between a walking epidural and a regular epidural? Great question. So let me answer the second part of that first. A straight on epidural is and they're both given exactly the same way, but it's the technique that's used and the skill of the anesthesiologist dictates whether you have a walking epidural or whether you have a regular epidural. The vast majority of anesthesiologists are trained in a straightforward epidural. When that happens, you are not able to stand on your own. You're not able to walk. You can't get out of bed. So that is, I would say, 90% of the epidurals that are given in this country. So I was fortunate enough to be at a hospital with the inventor of the walking epidural. And I had never seen it before. And I had been a midwife for, I think, probably 12 years before I had seen a walking epidural. And I was like blown away. So a walking epidural is an epidural that actually offers the same amount of pain relief, but a patient's able to get up and walk around. What I would do is I would ask your OB if he or she knows if they even offer a walking epidural at the hospital or birth center, where you're delivering. So most places, I would tell you, don't have the option for a walking epidural. If you do, fabulous. They're amazing. The pain relief is exactly the same, but with a walking epidural, you actually have the ability to get up and get out of bed and walk around. So that's the difference between the two. So is it ever too late to get an epidural? If it is your first baby, then the short answer is no, never too late. Right. So even if you're 9 centimeters fully dilated, you could still get an epidural. You're not going to miss a window. And again, sometimes women get to 9 centimeters or fully dilated and they think, I can't get it. I can't get an epidural, but you can. Some people have a hard time pushing because they feel everything. It becomes really difficult and then they don't push very effectively at all. And so sometimes getting an epidural even late in your labor isn't a bad idea to kind of relax your body enough to allow the head to come down. That's, excuse me, sort of a last ditch effort to keep a mom from getting a C-section. But with a first baby, you can get an epidural really at any time. Some people will tell you once you're fully dilated, no more epidural. All you have to do is push. And I do agree with that. I agree that once you're fully dilated, probably shouldn't get an epidural because you're not going to be able to push effectively. But there are certain circumstances where patients feel too much when they're pushing and all of a sudden they can't do it. So in an effort to keep that patient from having to have a C-section, that's when I might offer an epidural, even to somebody who's fully dilated, to see if I can get her to relax enough to allow the head to come down into the vagina so that she doesn't have to push very long. But in most cases, they'll say there's really no time where you can't get an epidural with a first baby. Second baby, third baby, usually once you're 8 centimeters or more, an epidural is not going to work because you're just going to move too quickly through labor for it to be effective. So first baby, you can get an epidural pretty much anytime. Most people are going to say not once you're fully dilated. No, then you just need to push. But that example I gave you is really like in the rare circumstance where somebody really couldn't push in the second stage. Okay. Anu asks, I've been reading about taking red raspberry leaf tea after full term. Any thoughts on that or when to take it? Yes, I will tell you all about that. Are there any other foods that you recommend that I take to prepare towards labor? Okay, so red raspberry leaf tea is helpful to balance maternal hormones. Do you ever have like an itch? What does that mean? Does that mean like somebody's thinking about you, or what is it when your nose itches? Somebody's talking about you? Or is it that you're going to get money? I like that idea. My nose keeps itching. I keep thinking maybe, okay, maybe I'm getting ready to win the lottery. I should do the Powerball. Okay, red raspberry leaf tea. So red raspberry leaf tea helps to balance maternal hormones. The truth of the matter is that oftentimes, in order to have that kind of medicinal effect, you have to drink quite a bit of red raspberry leaf tea. My patients will start drinking red raspberry leaf tea. I tell them they can actually drink it any time during labor, but if they're trying to get it to help to dilate the cervix a little bit or have an effect on labor in and of itself, you want to be drinking at least 2 to 3 cups a day, and you want to steep the bag to get a medicinal effect about 5 to 7 minutes. Most of us, when we have tea, we just kind of dip the tea bag 2 or 3 times and we throw the tea bag out. You're not going to get a medicinal effect from red raspberry leaf tea. But from 37 weeks on, if you steep that bag 5 to 7 minutes, let it sit in there. Yes, you're going to be drinking it lukewarm, but that will have enough of a medicinal effect to try to help start to soften the cervix. It is not going to put you into labor. I have never seen red raspberry leaf tea put anybody into labor. But does it help to kind of balance hormones a little bit? And the short answer is yes. Okay, there was a great study that looked at women in the final weeks of their labor ingesting dates. So medjool dates, Medjool, medjool dates, and what impact that had on the first stage of labor. And what they found was from 37 weeks on, women who took in 4 medjool dates a day for the last 3 weeks of their pregnancy actually had a first stage of labor that was shorter than women who didn't use dates. So that has actually been studied. So I usually tell women, yep, dates are totally fine, medjool dates. Now keep in mind, if you're diabetic, not an option because they're high in sugar. The other thing I recommend to my patients is using evening primrose oil, which is another supplement that oftentimes can help soften the cervix. So when we talk about evening primrose oil, it comes in 500 milligram capsules. It comes in 1,000 milligram capsules. It's something you'd want to talk to your healthcare provider about. With my patients, what I usually recommend for them is to use evening primrose oil starting at 37 weeks, and you take 2 capsules 3 times a day by mouth, and you put 1 in the vagina at bedtime. Now that's my gig, right? That's what I recommend for my patients when I'm in labor. You're going to want to have that conversation with your healthcare provider. If you're being delivered by a doctor, the likelihood is they're going to say, don't take that stuff. And the truth is because they don't know. They don't know anything about it. My personal background is in integrative and functional medicine. So I did a 3-year fellowship. I am very, knowledgeable in supplements and alternative medicine. So that is something that will oftentimes, is it going to put you into labor? No, it's not going to put you into labor, but it is going to definitely help to soften the cervix oftentimes. What is the best thing to help your body get ready for labor? All right. Listen, when I say this, the same mess that got you into this pregnancy scenario is the same mess that's going to get you out of it. So it's intercourse, right? Intercourse at the end of pregnancy, ejaculation inside in the vagina, releases prostaglandins. What are prostaglandins? Prostaglandins are what your body makes when your body's getting ready for labor. So there's not a woman alive that feels like having sex at the end of her pregnancy. I don't know any of them. My patients are like, Chris, can you please tell me something else? Because that is not what I feel like doing. I get it. But if you really want to know, like more than food, more than supplements, more than anything, it's regular intercourse in those last 3 weeks of pregnancy. Extraordinarily helpful. I can tell the difference when I'm checking a cervix of somebody who is having no sex during their pregnancy because they don't want to, or they don't have a desire, or they're afraid, versus somebody who's having regular intercourse in pregnancy. That cervix feels much softer, much riper. And if they need an induction, we're using much less Pitocin because they already have a prostaglandin effect on the cervix. So, so that's a great question. And although you can try all of those things, the one thing that's going to work better than all of those is if you have sex at the end of your pregnancy. Okay. Let's see. Amy and Robert. Let's see. Okay, I know, great question. I know people reference bringing snacks when you come to the hospital. When do you want to stop eating? I know your body needs fuel, but are you really just following your body's signs of comfort versus nausea? Great question. Um, Okay, early stages of labor, you still have an appetite. You really do. Like you feel like I'm hungry, I'm thirsty. You want to keep yourself pretty well hydrated because labor is like a marathon, right? You never run a race without taking water at certain water stops during, your run. And so labor is like that too, hydration. But the idea of eating when patients get into active labor, 4 centimeters, 5 centimeters, 6 centimeters, 7, 8, 9, right? We define early labor as 0 to 6 centimeters, but really at about 4, 5, 6 centimeters, your appetite kind of goes away. So I usually tell people, yeah, you can bring some snacks, but you're really not going to be hungry, right? When you start getting into the real active phase of labor, 6, 7, 8, 9 centimeters, more often than not, you're feeling like you want to vomit. So you're not eating at that point, but you can certainly drink, right? Water, Gatorade, whatever it is. I didn't bring snacks at any time when I was in labor because oftentimes, people bring snacks and it's fine to pack them, but you just don't use them. They stay in your suitcase and then you go home with them because usually the earlier phase of labor, when you're hungry, you're still at home, right? You're not even coming to the hospital at that point. So the goal is to get to the hospital when you're ending the very latter part of the early phase of labor, 4, 5, 6 centimeters, right? If you get to the hospital 6, 7, 8, 9 centimeters, I'm telling you, I promise you, food is going to be the last thing on your mind. It's a rare patient that's 7 or 8 centimeters and says to me like, I'm hungry. It just rarely happens. Okay. But it's a great question. Okay. Alexandra, great question. What happens if the epidural fails? Are you able to receive another? And absolutely. If you have an epidural, you should feel no pain. You really shouldn't. You should be very comfortable with an epidural. Some patients can't even feel their body contracting at that point. Now, some epidurals will give you a really good epidural. You'll feel your contractions, but you won't feel pain with them. That's a great epidural. So if you have pain while an epidural has been placed, you need to let your nurse know so they can call the anesthesiologist. Absolutely. And it will either be repositioned sometimes or redosed and sometimes actually replaced, right? So you really, when you have an epidural, you want to be fairly pain-free, maybe feeling the very peak of your contraction and not really feeling a tremendous amount of pain. Sometimes what happens with an epidural is you'll feel very comfortable, but you'll have like one area somewhere, I'm just pointing here, which we call a window, where you're just not getting pain relief in that area. And then your anesthesiologist will come in, probably redose the epidural and they'll turn you on your side so that the medication gets sort of, diffused to the area where you have that window of pain. But the short answer to your question is yes, absolutely. You can have an epidural replaced. Okay. Maria and Chris, if I am in early labor at home, will I make it in time to get an epidural once I get to the hospital? Excellent question. Or do you only stay home to labor until 511 if I want to go natural once I get to the hospital? Great question. First baby, whether you want an epidural or not, think about what we said earlier. As a general rule, when you're contracting every 3 to 4 minutes for about 3 to 4 hours, right? You're generally 2 to 3 centimeters dilated. And most women think they're 7 or 8 centimeters dilated. So they come in so discouraged because they don't realize that that's the process. It's a long time with a first baby. So no, if you want an epidural, you can certainly still stay home for that 511 rule, right? If you can manage it, right? Most women who want to go naturally will really strive for that 511 rule, right? Because they're really trying to have a baby without the assistance of pain relief. If you know you want an epidural, that 511 rule is probably still going to get you to the hospital, maybe 2 to 3 centimeters, maybe if you're lucky, right? So just know that it's not that 511 rule doesn't exist whether you want to go naturally or whether you want an epidural, because the likelihood is you're still going to hit the hospital at the early phase of labor if you follow that rule 511. All right. Okay, so let me see what time it is. I have 1:56 my time where I am. So if you're on the West Coast, what is that? 9:56. Let's take a 15-minute break. What time is that going to bring us back? That is going to be 2 o'clock my time, 2:15 minus 4, 2:11. Okay, let's 2:11.